Hello and welcome to my channel Endocrine Talkies. And I'm going to be speaking to you about the approach to hyponatremia in a very simple manner. Hyponatremia is something which most of us uh, in every specialty, be it medical or surgical, face, especially in hospital patients and also in outdoor setting. And I'm sure most of you would have read the theoretical part. Uh, there'll be a lot of algorithms and a lot of approaches to management. So I will be going through how exactly to go about it in a very simple manner so that it is easily can be done by anybody, that is any doctor from any specialty. So I'm sure all of you must be knowing that hyponatremia is mainly a disorder of water balance. And as you can see, Aquaman is balancing in the water so that he's avoiding sharks on either side. So if you fall onto either side, then there can be a big problem in management. So you need to balance the water properly. So again, important definitions. Most of you will be knowing regarding all this. However, let me go through it again. So hyponatremia is when your sodium levels are less than 135 milliequivalent per liter, and it can be classified as acute and chronic. If it is arising within 48 hours, it's called acute. If it is more than or equal to more than or greater than 48 hours, it's called chronic, and it can be classified as mild, moderate, and severe. Mild is between 130 and 134. Moderate is between 125 and 129, and severe is less than 125. And at least 35% of admitted patients in hospitals have hyponatremia. So it is important for us to know how exactly to diagnose hyponatremia and to manage it properly without causing overcorrection and the dreaded complication of osmotic demyelination. So again, I'm sure in textbooks you would have read that you need to differentiate acute, chronic, symptomatic, asymptomatic. You need to assess the volume status. So all these, although theoretically it sounds very easy, but in practice it's difficult to know, especially if it is acute or chronic hyponatremia. Many a time you don't know the exact duration of the hyponatremia. And symptoms are very non-specific, especially in elderly age group. The symptoms can be very non-specific, and you would have seen patients with sodium of maybe 110, 105, and when you see them, they seem perfectly fine. So, and so it does not always correlate with the severity. And regarding volume status, again, there is low sensitivity and specificity. So when you examine a patient, you might not be able to assess it clearly. And whenever you're going through history and examination, always ask regarding what the medications the patient is taking and regarding how much fluid intake the patient is having, especially inpatient, how much of IV fluids are going is very important. So if at all you're not sure regarding the duration, uh, then it is better to treat as chronic hyponatremia. So as you all know, when your hyponatremia happens, you have if it is a chronic hyponatremia because of the gradual fall in serum osmolality, you have the loss of cellular osmolytes, and the brain gets adapted to that, well adapted to that. And if it is an acute hyponatremia, there is a sudden decrease in osmolality, and what happens is you can have cerebral edema and the patient can present with seizures. So acute hyponatremia needs to be immediately managed. However, if you rapidly treat chronic hyponatremia, it can lead to sudden complications that it can lead to osmotic demyelination. So just imagine that you are going into a movie theater and like the treatment of hyponatremia is like going to see a movie in a theater. So when you go into a theater, first checkpoint is your the guard which will be standing next to the door. They'll want to see if your ticket is original or it is fake. And so if your ticket is fake, they'll tell you to get lost. If it is an original ticket, then you can enter inside. So when your serum osmolality is high or normal, it is called as fake or pseudo hyponatremia. And if it is low, that means it is original or true hyponatremia. So so whenever you're calculating the serum osmolality, so you can measure it in the lab. Uh, I'm sure many hospitals don't have that facility, and you can also calculate it. But whenever you're measuring it in a lab, always you need to correlate with the calculated serum osmolality as well, as I've given in this formula above. I'm sure many of you will know regarding that. And fake hyponatremia, or you can say pseudo hyponatremia. It can be again, it can be isotonic hyponatremia or hypertonic hyponatremia. So isotonic can be due to hyperlipidemia, hypertriglyceridemia, cholestasis, hypoproteinemia, myelodysplasia, myeloma, and even IVIG therapy can cause that. And hypertonic hyponatremia is when you have exogenous infusion of mannitol, glucose, glycine, sorbitol, even alcohol intake, uh, high blood glucose itself. So hyperglycemia itself can cause hyponatremia, and there is a formula to calculate the corrected sodium depending on the blood glucose. Even elevated urea and also iodinated contrast can cause hypertonic hyponatremia. However, a normal serum osmolality doesn't always rule out true hyponatremia because patient may have two things taking place simultaneously. So there can be a patient with a cerebrovascular accident on mannitol. So cerebrovascular accident or a subarachnoid hemorrhage can cause hyponatremia by itself, and you can have patient or having getting mannitol. So that can cause a falsely normal serum osmolality. And another example is a patient with chronic liver disease and with recent alcohol intake can also have a falsely elevated uh, serum osmolality. So once you have diagnosed true hyponatremia, so you have entered into the theater after the first checkpoint, and before entering into the movie screen, you need to buy your cold drinks and your popcorn. So the next step is to calculate the urine osmolality and the urine sodium. So whenever you're interpreting urine reports, you need to take into consideration the previous treatment the patient has been receiving. So a previous intake of sodium or sodium containing fluids can falsely alter these reports. Patient with chronic kidney disease, heart failure also can have difficulty in interpreting these urine reports and also especially diuretics. So many a time what happens, especially from a super specialist point of view, from endocrinology, we get referrals for hyponatremia which has already been treated by many of the other specialties. So many a time these tests are not sent initially. So when you send it at a later stage, again it becomes difficult in interpretation. So whenever you see a patient with hyponatremia, you make sure that these reports, these investigations are sent before starting the treatment of the same. So when you are measuring urine osmolality, what are we actually trying to know? So we are trying to know mainly the status of the antidiuretic hormone. So whenever the ADH is active or it is on, you will have a very concentrated urine, as you can see in this picture. And if your ADH is off, you'll have more dilute or urine just like water. So if the urine osmolality test is not available in your hospital, something which is easier to do is a urine dipstick test. So with the dipstick, you can find out the specific gravity of the urine, and the specific gravity with that you can correlate with the urine osmolality. So a specific gravity of 1.003 correlates to around 100 milliosmoles per liter of urine osmolality. And as you can see in the table, 1.010 is 300 and 1.020 is around 500 milliosmoles per liter. So you can have an idea even if this test is not there in your hospital. So whenever you have higher ADH secretion, you will have a more concentrated urine. So depending on urine osmolality, you get to know, you can classify it again. So if your urine osmolality is, you have true hyponatremia and your urine osmolality is less than 100, probably it's due to primary polydipsia, T and TOS syndrome, and Beer-Portomania. So T and TOS syndrome is something which is again seen more in the Western population. It's again because your elderly people are they don't have caregivers, they're left alone, so they go and they eat mainly only bread or toast, and they have a lot of tea. So if they have a background history of a CKD and they're taking more of fluids, uh, and toast has less amount of salt, all these things can also lead to uh, hyponatremia. So if you have a urine osmolality of more than 100, that is when you go for urine sodium and you assess the volume status. So whenever you look at the urine osmolality, so the advantage of urine osmolality is whenever you're treating also, you can get a real-time information about what is going on. And even while looking at the catheter bag, a patient who's catheterized, it's or even you can tell the patient to collect the urine and keep. The color of the urine is very important. So suppose on one day when you see the patient is having very concentrated dark colored urine, and the next day itself the patient is having very light urine or not that concentrated urine. That means you might be actually overcorrecting. Your treatment might be leading to overcorrection. So that can show you that you might be in trouble or you're in trouble. So you need to be careful. So it is important to monitor, especially the urine output of these patients, to know if you're rapidly correcting or not. And urine osmolality and urine dipstick test can give you a real-time information about the same. So whenever you're looking at urine sodium, again, why are you doing the urine sodium? Urine sodium is to know the status of the renin-angiotensin-aldosterone mechanism. That is the RAS. So what does the RAS do? So the RAS causes sodium and sodium retention, and it helps increases the blood pressure. So whenever there is an effective arterial blood volume which is low, uh, the RAS becomes active. So whenever the RAS is active, usually the ADH also uh, becomes active when there is more than 15% reduction in the effective arterial blood volume. So presence of ADH secretion with an active RAS is something which is appropriate. However, ADH secretion without an active RAS is something called which is inappropriate. So usually when the RAS is active, the ADH secretion occurs only if there is a more than 50% reduction in the effective arterial blood volume. But ADH secretion in the absence of an active RAS is something which is inappropriate. So when you're looking at the urine osmolality and the urine sodium, If you have a high urine osmolality, which is showing that ADH is active, the urine is concentrated, and your urine sodium is low, that means the RAS is working. Urine is the RAS is acting and it is causing sodium retention to help increase the blood pressure. So that is an appropriate ADH secretion. However, you have a high urine osmolality, that is a concentrated urine with a high urine sodium. That means the RAS is inactive. So urine sodium is being excreted in the urine. That is a inappropriate ADH secretion. And also some diuretics can also cause that. So whenever patient is on diuretics, you need to be careful with the interpretation, as I mentioned earlier. So again, this flow chart you would have seen. So after you're doing all this, you've calculated the serum osmolality, urine osmolality, and urine sodium. Then you try and assess the volume status. Again, it is easier said than done. When the patient is having CLD, congestive cardiac failure with your pedal edema, anasarca, all that, it is easier to know that. But again, when you're hypovolumic, even euvolumic, it's difficult to assess. So depending on the volume status, then you try and classify the patient. So if the patient is hypovolumic and the urine sodium is high, that means you have a renal excretion, diuretic excess, mineralocorticoid deficiency, salt losing deficiency, ketonuria, osmotic diuresis, cerebral salt wasting syndrome. If you have hypovolemia and low sodium, that means you have an extra renal loss uh, of sodium. It can be due to vomiting, diarrhea, burns, pancreatitis, and trauma. When you're looking at the volume status, if you are euvolemic and you have a elevated urine sodium, most commonly it is due to SIADH, that is a syndrome of inappropriate ADH secretion. So the SIDH can be due to many causes. That list I have not put here. I'm sure you can go through it in your textbooks or even online. Glucocorticoid deficiency, hypothyroidism, stress, and also drugs can also cause this. If the patient is hypervolemic, then again you need to assess the urine sodium. If it is an acute or chronic renal failure, your urine sodium can be high. If you have nephrotic syndrome, CLD, or cardiac failure, your urine sodium can be low. There are some other tests which are not routinely used, but again, it can be helpful in certain conditions. So, it is to calculate the fractional excretion of either sodium, fractional excretion of uric acid, fractional excretion of urea, and even serum uric acid. So, to calculate the fractional excretion, there is a formula of any of these. This is the formula that you use. So, you check for the urine, either the urine sodium, the urine uric acid, or urine urea, and you look at the same levels in the plasma as well, and then you calculate the excretion with this formula. So, in certain situations, especially if the patient is on diuretics, it can help you differentiate between SIADH and uh, not SIADH. So, the data shows that fractional excretion of uric acid and fractional excretion of urea may be slightly better to differentiate both, and compared to all your other tests which you do, urine sodium and all those things, especially when the patient is on diuretics. So in such cases, it may be helpful to do this test. So if you have SIDH, your fractional excretion of sodium will be elevated. Your uric acid, that is a serum uric acid, will be low. It can be less than 4. Fractional excretion of uric acid will be increased, and fractional excretion of urea will also be increased. Whereas if it is a appropriate ADH secretion, that is when there is a low effective arterial blood volume, all these things will be in the opposite direction. Other important tests which you need to do is thyroid function tests, cortisol to rule out glucocorticoid deficiency. You need to do a chest and a brain imaging also, because all these things can lead to hyponatremia. So again, this is a flow chart. So once you have diagnosed true hyponatremia, you need to know whether it's acute or patient has severe symptoms. The patient is having severe symptoms, you need to immediately treat with hypertonic saline. If the patient is not having severe symptoms, then you go to your next checkpoint, which is the urine osmolality. See if the urine osmolality is high or it is low, that is more than 100 or less than 100. If it is more than 100, then you go for urine sodium. And urine sodium, different textbooks and different guidelines mention different cutoffs. The previous flowchart that I showed you, the cutoff was 20. Over here, the cutoff they're saying it's 30. So you can use any one. Again, 20 to 30 is a gray area. So if the urine sodium is low, so then you need to know whether it is a patient is hypovolemic or hypervolemic. So if it is hypervolemic, probably it is due to heart failure, liver cirrhosis, nephrotic syndrome. Patient is hypovolemic, it is due to third space loss. If the urine sodium is more than 30, again, is it hypervolemic? Is it euvolemic? So if it is euvolemic, uh, it is because of SIADH and even secondary adrenal insufficiency and hypothyroidism. If the patient is hypovolemic, probably it's due to renal salt wasting, primary adrenal insufficiency, and cerebral salt wasting. So I hope you're enjoying the movie till now. So now I'd like to go into the management. So again, who should be treated actively? Patients with severe hyponatremia should be treated actively. That is a sodium less than 125. Patient with acute hyponatremia, that is within less than 48 hours, should be treated actively. Patient with severe or moderate symptoms, if it is acute or chronic. So what are the severe symptoms? So seizure, coma, respiratory arrest. Again, you need to treat actively. Moderate symptoms include confusion, altered mental status, nausea, gait abnormalities, and falls. So what is the emergency management? So I'm sure most of you know it is hypertonic saline. So the recommendations say that bolus injections of 3% NaCl is to be given over 10 to 20 minutes, up to 3 times it can be given. So the main aim is to correct it by around 4 to 6 milliequivalent per liter in 1 to 2 hours. And you need to monitor sodium after every bolus and also 6th hourly for 24 hours when you're giving this bolus doses. It is recommendation that the correction limit should be 10 milliequivalents per liter in the first 24 hours and 18 milliequivalents per liter in 48 hours. However, many experts recommend not to go above 8 milliequivalent per liter in the first 24 hours. So regarding uh, whether, I'm sure most of us use a slow infusion of hypertonic saline, and there has been studies comparing slow continuous infusion of hypertonic saline versus these rapid intermittent bolus, as I had mentioned earlier, giving bolus over 10 to 20 minutes up to 3 times. Is there actually a difference in giving both? Can we give it slowly? So rapid intermittent bolus, again, it achieves a faster correction of sodium. However, there is a risk of overcorrection, and you might need to do some re-lowering therapy, like giving dextrose to giving excess water so that the sodium is again not overcorrected. And in none of these trials, they have shown that there is any cases of osmotic demyelination. So whether you want to give rapid intermittent boluses or you want to give slow continuous infusion, you need to take a personal decisions on that. So you need to take this with a pinch of salt. So whether you want to achieve a faster correction of sodium, however, there is also a risk of overcorrection, or do you want to go slowly? It is up to you to decide which to follow. There are many formulas regarding the correction of sodium I'm sure most of you must have heard many formulas, and it is very cumbersome to use this in daily practice, and especially when patients come to emergency. Again, there is still no consensus regarding what is the initial infusion rate which needs to be used. And again, there is also continuous change in renal functions of the patients, also in the urine output of the patient. So, whether this can be continued, these formulas can be used for 24 to 48 hours altogether, it's again difficult. A simple rate calculator, which has been mentioned, is that the initial infusion rate of 3% NaCl can be weighed into the desired correction rate which you need, that is per hour. Again, still, if you use this formula, you might not get the desired correction. But again, you can frequently monitor the sodium and you can either increase or decrease this rate. If you're giving 3% NaCl, when should you stop using NaCl? So once your patient is not symptomatic anymore, you stop giving 3% NaCl. If you have reached a sodium above 125, again, you can consider stopping it. The rate of correction has reached a limit of 8 milliequivalent per liter in 24 hours. Then you stop using 3% NaCl. Then you convert to the other therapies which are available, either doing fluid restriction or using your Vaptans or using your added salt and furosemide, all those things. Suppose you overcorrect, then what do you do? Again, this is a controversial. So you're trying to correct sodium, and suppose you gone above the limit, the cutoff which I have mentioned in the previous slides. What do you do? Do you again bring the sodium down further? So that is again controversial, but there are some articles which mention that injection desmopressin, you can increase the free water or give IV dextrose so that you have brought it back into the correction limit for the 24 hours. So again, how many of you do this? I'm not sure. But again, it is up to you to decide. Suppose you have overcorrected more than 12 or 13 in 24 hours, then do you need to, whether you're putting the patient at risk for osmotic demyelination or not. So if the patient is at a high risk, then you can consider doing this treatment to bring it back into the correction limit. So who are at a risk of having overcorrection? So especially patients with severe hyponatremia of less than 105 milliequivalent per liter, patients with concurrent hypokalemia, patients with advanced liver disease, malnutrition, history of alcoholism, even patients who are having adrenal insufficiency, such patients are at a high risk of having osmotic demyelination. And the risk factors of overcorrection include treatment with Vaptans, uh, is something which can cause overcorrection. So this is a drug which is commonly used in most hospitals, and you need to be cautious while using these Vaptans. It's not that okay, you just give a Vaptan and everything will be done. It'll be perfectly fine. It's not like that. And if a patient has SIADH due to a certain cause and that cause has been eliminated again, there is a chance of overcorrection. If you have adrenal insufficiency, you have a chance of overcorrection. Patient who was using diuretics, which was the cause of hyponatremia, and discontinuation of thiazide diuretics along with using treatment for hyponatremia such as hypertonic saline fluid restriction, again you have a high risk of overcorrection. If the patient has concurrent correction of hypokalemia also, you are at a higher risk of overcorrection. So in these scenarios, you need to be careful. You need to prevent overcorrection and in certain cases, you need to be careful of osmotic demyelination as well. So what about non-emergency management? So if it is hypovolemic hypernatremia, that is a contracted fluid status, what you need to do is give isotonic fluids. It's a normal saline or crystalloids. You should not give Vaptans in a patient with hypovolemic hyponatremia because you can worsen the hypovolemia. In hypovolemic hyponatremia, sorry about that, this is hyponatremia. So let's cut that off. You need to uh, you need to do fluid restrictions. You need to give loop diuretics, uh, potassium correction if there is hypokalemia. Albumin can be given, especially in patients with chronic liver disease. And if you have cirrhosis, again, aptan is again contraindicated. What about patients with SIADH? Fluid restriction is something which we do in patients with SIADH, giving solutes such as salt and urea, furosemide and Vaptans is also used in SIADH. Again, fluid restrictions, it's easier to tell patients to do fluid restrictions. But again, something which is easier to do is you can give a bottle to the patient. So if you are telling the patient you shouldn't have only 1 liter or 1.5 liters per day, you tell them, okay, I'm giving you this water bottle or 1.5 liters of a water bottle which is of 1.5 liters. You have only this much today. Don't have more than that. That is easier for the patient to follow. Uh, and another way to do fluid restriction is by using this formula: urine sodium, urine potassium, and plasma sodium. So if it is more than one, you recommend less than 500 ml per day. If it is one, 500 to 700, and if it is less than one, you recommend less than 1 liter per day. So, in which patients will fluid restriction work? Again, there are some scenarios which can predict failure of fluid restrictions. That is, patients with very high urine osmolality, more than 500, probably there will be failure of fluid restriction. Patient with a low urine volume of less than 1.5 liter ml per day, 1500 ml per day, and even after doing fluid restriction of 20 of less than 1 liter for 24 to 48 hours, if your increase in sodium is less than 2, probably fluid restriction is not working and you might need to go for other methods. Giving solutes. So the point of giving solutes is to increase the free water excretion. So you're giving added salt to increase free water excretion, not to exactly increase. You're giving salt to increase the sodium. You're increasing free water excretion so that the sodium improves. So you can give 2 gram thrice daily. Again, added salt alone usually will not work. You need to do it along with fluid restriction. And giving too much of salt can make patient very thirsty, and especially in patients with hypertension, you need to be cautious. Again, giving urea is something which is done earlier. Again, because of palatability issues, you can give it along with juice. And giving 30 gram of urea can excrete about 1 liter of free water. Protein also you can increase because protein is converted into urea, and that itself can also increase free water excretion. Furosemide is again something which increases free water excretion. Again, it can be combined with oral salt, so you can give around 20 to 40 mg per day in patients with SIDH. Vaptans. So Vaptans is an important drug, but it is again commonly misused. So you need to use these medications cautiously and in the right patients. So there are many Vaptans which are available: Conivaptan, Tolvaptan, uh, Lixivaptan, and also Satavaptan. So Tolvaptan is something which is commonly available uh, in our area. So if you are starting Tolvaptan, preferably it should be done only in hospitalized patients because you need to monitor the correction. Do not use it for patients with hypovolemia or hypovolemic hyponatremia because you can increase the hypovolemia further. It is preferable to use Vaptans in patients with severe hyponatremia, that is less than 125. If a patient have a sodium above 125, if it is not improving with fluid restriction, then you can consider using a Vaptan. So what is the starting dose? Again, it's recommended that you start with 15 mg on first day. Some also recommend starting on 7.5 also. And you can increase the dose to 30 and 60 at 24-hour intervals. But again, you need to keep a close watch on the sodium because again, you can cause overcorrection. So instead of giving it as a continuous daily dose, it is better to monitor the sodium and decide whether to give it the next day. So you monitor every 6 hours to avoid overcorrection. And if you are giving a Vaptan, don't do fluid restriction along with that because that will again lead to overcorrection of sodium and it can lead to complications. What are the adverse effects of Vaptan? So it can cause headache, dry mouth, hypokalemia, thirst, increased urinary frequency, uh, orthostatic hypotension, and in patient with advanced renal disease, again, it might not be that effective. Patient with cirrhosis and advanced liver disease, you need to be careful because it is hepatotoxic. So how long can you give Vaptans? So the guidelines say that you should not give it for more than 30 days. But in clinical practice, especially elderly patients, we do find patients with hyponatremia who are not getting corrected at all. So in some people, you might need to give prolonged Vaptans. But again, recommendations say that should not give it for more than 30 days. So again, it is something which is off-label. So you need to be cautious if you're giving it for more than 30 days. So if there is, as I mentioned in the history, it is important to take the drug history. And if there are any other offending agents, you need to make sure those drugs are stopped. There's a big list of drugs which causes hyponatremia. So you need to be careful with that. And if there's any other etiologies, you need to treat it. Adrenal insufficiency and hypothyroidism, of course, has to be treated. And especially patients who are in pain and with nausea, this can also aggravate ADH secretion, which can cause hyponatremia. So that also needs to be adequately managed. So the final take-home point is do not forget about pseudohyponatremia. Treat patients with symptoms and acute hyponatremia actively. Formulas for calculation again is very cumbersome and it is difficult to do. Avoid aggressive therapy once sodium is more than 125 or the symptoms have resolved, and frequent monitoring of sodium is required to prevent overcorrection. Thank you. I hope that was helpful for you. And if there are any doubts, you can mention in the comments or you can contact me via email. Thanks.